Good evening, everybody. And I've been given the topic of adrenal hypertension. And there is so much to cover on this topic in short time. I'll try to do justice. Regarding hypertension, which is like the adrenal hypertension, I think it is much more prevalent. And as Dr. Sahai rightly pointed out, we should screen more, and more. Unfortunately, like there's one extreme scenario where we talk about screening everyone. However, the ground reality is that even those who have severe hypokalemia, even those are not screened. So it's just the opposite spectrum, and it actually baffles me that nobody talks about primary aldosteronism. It's if you see on social media, people are talking about thyroid. Everybody knows about thyroid. If you ask the patients, have you heard about adrenal? So good initiative, and people should talk about adrenal more, and it's much more common. I Even the essential hypertension, it's a spectrum. So it's not black and white, like you have primary aldosteronism or you don't. It's all actually a spectrum. And the spectrum, now more and more papers are coming up that even it starts from the normotension, because that's like a subclinical stage. So that is another topic of discussion altogether. But I just want to emphasize that we should screen more and more and more. That's the message should be. So, adrenal, this is such an interesting heading. I would really credit the one who gave this heading, that it's actually we are like acting like a Sherlock Holmes, especially in younger patients who are presenting with hypertension. So if you talk about scope of the problem, scope is unlimited because hypertension is such an important public health challenge. And majority of patients, although hypertension is primary, subgroup may have secondary cause. So what are those patients who may have secondary cause? So if you look according to age, if you are seeing in the clinic a younger patient with the history of hypertension, especially severe hypertension, resistant hypertension, you should definitely, rather than just prescribing medicine, evaluate the cause. That is so important. Comes our role as Sherlock Holmes. So it begins with history taking, the good old history taking. That is the starting point of everything. So we begin with the onset, history suggestive of any renal disease, past history, family history, history of spells, taking blood pressure in both upper limb, lower limb, examining them. So that is the first step. This kind of proforma we had in All India Institute of Medical Sciences, where we'll just, at that time, it was a big task to fill them all. But then retrospectively, you realize that filling all the details, it's really important. All of these, they are clues for Sherlock Holmes to actually know what is happening. These are the routine biochemical investigations we did, and all the hormonal investigations. And then I'll be talking more about aldosterone and renin, which are the key heroes here. And of course, doing all the basic examination, not to miss out on other non-endocrine causes as well. Now, this is one slide which is so important to understand the cause of adrenal hypertension. So, adrenal hypertension is due to excess of autonomous production of aldosterone. So, it can either be aldosterone or something like aldosterone. In aldosterone or any other mineralocorticoid. And in that case, renin will be low. So it is basically low renin hypertension, either due to high aldosterone or due to high something like aldosterone. So that is what we will be talking about. So the endocrine hypertension can be either adrenal dependent, thyroid, pituitary dependent, or genetic monogenic causes can be there. So coming to our cause, as Dr. Sahai gave in the overview also, pheochromocytoma, primary aldosteronism, then there is CAH, and then Cushing syndrome. So this is a very important figure. From here, you can understand which are the basic uh, workup which is required. So pheochromocytoma, when to consider is the history, which can tell a clue. In pheochromocytoma, it's quite typical history, which with a paroxysmal symptoms. And how to evaluate is fractionated metanephrines. Primary aldosteronism, I will talk more about that. Then there is CAH, and we have the renovascular hypertension and other causes. So this is very important to take history properly. So basically, as I told previously, the hypertension can be low renin with high aldosterone. So that is basically primary aldosteronism with different forms of primary aldosteronism, or low renin with the low renin and low aldosterone, which can be due to CAH. Basically, it is high deoxycorticosterone, or it's apparent mineralocorticoid excess due to genetic cause. So now coming to pheochromocytoma, although pheochromocytoma is, we like to evaluate for pheochromocytoma, like endocrinologists like to evaluate them, but it's really very rare. So we are talking about less than 0.1% of hypertensive patients who will harbor a pheochromocytoma. However, there are some factors or some clues in the history. If they are, like, for example, a patient coming with a labile hypertension and an adrenal mass, of course, we have to think about pheochromocytoma. So the pre-test probability will be depending upon the history and the other features. So these are the common symptoms. Pheochromocytoma is said to be a great masquerader. So it has a lot of variable symptom. And they can be headache, sweating, and palpitation constitute the classic triad of pheochromocytoma. Then, while workup of pheochromocytoma, it's very important that there are a lot of drugs which can interfere, and then it's important to discontinue them at least 2 weeks before the evaluation. This is the workup chart. So discontinue the interfering medication. Then the workup depends upon the pre-test probability. If the pre-test probability is high, we can go with even plasma fractionated metanephrines or the 24-hour urinary fractionated metanephrines. But if it is low, we have to go with the 24-hour urinary fractionated metanephrines. And then the second step is localization. We have to do the adrenal imaging and then functional imaging to confirm. And then genetic testing, of course, and then surgical resection. Now coming to Cushing syndrome. So Cushing syndrome, as we discussed initially, that exogenous glucocorticoid administration, unfortunately, is one of the most common cause. Then the endogenous can be endogenous Cushing. Again, it's a rare condition. We see more during our training because we are at referral center, while in our clinics we are basically more of seeing the exogenous glucocorticoid administration. So this is a chart of workup of Cushing. First is confirming the diagnosis, which can be by either 24-hour urinary free cortisol or by taking midnight salivary cortisol and dexamethasone suppression test. Then the second step is to the plasma ACTH, and the causes depend upon ACTH dependent causes, ACTH independent cause. Since we are talking about adrenal today, so the adrenal is in this, ACTH is suppressed. So then we do a CT scan, and then we can find out what is the cause. Now coming to what other cause, like low renin and low aldosterone. So it is some other factor which is acting like a mineralocorticoid. So it is basically, if we see this chart and we remember it, this chart we have read hundreds of times, and of course have to re-look at least I have to re-look again at this chart. So in this one, this is basically adrenal steroid synthesis. And in this one, any cause which is increasing the mineralocorticoid or its precursor can cause hypertension. So if aldosterone is being increased, that is high aldosterone and low renin, or if anything if the precursor is increased, that will also cause hypertension. So in CAH, the two basic causes are 11 beta hydroxylase deficiency and 17 alpha hydroxylase deficiency. And this will appear when we will do the test as low aldosterone and low renin, because aldosterone is low, but the precursors are high. Now, coming to the most common cause, which I really want to talk about, because it's not like Cushing or FEO or even CAH, which are less rarer and we see less often. If you start screening for primary aldosteronism, I believe you will really find a lot of cases. So coming to primary aldosterone, it's most common cause of secondary hypertension, and it's almost like 10%. Imagine 31% of population have hypertension and around 10% at least. That's even a conservative estimate. Maybe it's even more. So they have primary aldosteronism. Why should we screen for primary aldosteronism? So previously it was thought that it's a benign condition. But aldosterone is not benign. It can affect everything. It can cause affect gluconeogenesis. It can cause dyslipidemia, hypertension, cardiac fibrosis, vascular endothelial dysfunction. So aldosteronism is neither rare nor benign. So that is one thing, if we remember, that's like it's not rare and not benign. Very important to understand this. So why should we screen? Because if we match essential hypertension patients and aldosteronism patients, they have 4 times increases for stroke, 6 times for MI, 12 times for AF. And this one, the specific medications, they are the game changers. So we should screen for PA. So it's not just the matter of controlling blood pressure, it's a matter of nullifying the aldosterone. That is the key. So whom should we screen? That's a very important question. Previously, this is our study, which was published in Clinical Endocrinology, and it was shown that young hypertensive patients, 18.8% patients screened positive, and prevalence, it was found that 17.8% patients had confirmed primary aldosteronism in young patients. So especially the young patients, we should definitely screen for primary aldosteronism. Then there's similar study from KEM Mumbai. They also found a prevalence of 4%, but they took patients with type 2 diabetes mellitus. So coming to the traditional. So the traditional is like hypertension with hypokalemia, resistant hypertension, adrenal incidentuloma, then severe hypertension. But newer concept, all patients with hypertension. Then what is the cutoff? Older cutoff, 15 at least, but now it's like it's a spectrum. So at least anything aldosterone more than 10 and suppressed renin constitute a positive screen. Just forget about the ratio. Just look at individually aldosterone and renin. So even the current Japanese guidelines, they recommend screening all hypertensive subjects. This is the older, this is from 2020 guidelines, and they have included now hypertension at a young age, which was not previously there as a screening criteria individually. So hypertension as a young age should be considered as a separate category. This is again from 23 Korean guidelines, and they cited our study. They also included, other than the traditional screening indications, hypertension at a younger age to be included. So ideally, all patients, but at least those in the guidelines should be screened. Like anybody who is having resistant hypertension, who is having severe hypertension, they should be screened for primary aldosteronism. Ideal routine screening on first presentation for hypertension. But the reality is poor screening rates worldwide. This is data from the developed world. We don't have even the other countries' data. It shows that just 2% hypertension are screened. Why? Why do we have such poor screening rates worldwide? The reason is that less than 1% of patients who should be screened are screened. The reason is that the diagnostic algorithm is considered so complex that it's considered daunting. And secondly, of course, there's not enough awareness about this condition. How to screen? This is the classification which I initially discussed, that aldosterone producing adenoma, bilateral hyperplasia, and then familial hyperaldosteronism are the causes of classification. This is the algorithm, which is simple. All patients test at least once. Just take a morning sample, simple, plasma aldosterone and renin. If more than 10 aldosterone suppressed renin, it's positive. Do the confirmatory test, and then next step after the confirmatory test is the CT scan. If the CT scan shows clear cut adenoma and the patient is young is less than 35, then we can directly go for surgery, otherwise do adrenal venous sampling. So these are the medications which can interfere with aldosterone renin ratio. However, you can screen and continue with all the usual medications. If possible, to stop spironolactone for 4 weeks, but all the usual medicines can be continued. One very important thing is that hypokalemia must be corrected, because potassium is a very powerful regulator of aldosterone. So that will get a false result. It's very important to correct potassium and ask the patients to not to restrict the salt. If taking spironolactone, withdraw it for 4 weeks, like spironolactone, eplerenone, withdraw them. Other medications can continue. The cutoff is also, there's a big debate on the cutoff. Rather than going for this traditional cutoff, just see the absolute value of aldosterone and renin. Different guidelines, they mention different cutoffs. Regarding the confirmatory test, again, lot of variability. We were using saline infusion test as a cutoff. Now there's a seated saline infusion test in which more than 6, if it is there, post saline, post 6 nanogram per deciliter, aldosterone is considered positive. So now the newer concepts. One newer concept is that all patients should have their at least renin tested. Those who have suppressed renin should be referred to an expert center. And then there is a 24-hour urinary sodium level and aldosterone level, which is being done. And now it's being studied like a spectrum. Why should we do subtyping? Why not just start spironolactone in all the patient? So the reason is that if the patient is having adenoma, then of course there's a chance for cure, and just maybe the MR antagonist therapy is not enough for them. So severe, if they have the severe form, then surgery is the optimal treatment for them rather than just giving them spironolactone. Incomplete evaluation and incomplete treatment is suboptimal management. Coming to adrenal venous sampling, adrenal venous sampling is performed to assess whether autonomous hormone production is unilateral or bilateral. This is our AIMS protocol, in which we collected first from right adrenal vein, then infrarenal IVC, then left adrenal vein, and infrarenal IVC. These are the indices which we used, and lateralization index, if the aldosterone cortisol ratio is more than 4, it suggested unilateral primary aldosteronism. Now, there are a lot of nuclear studies which are coming up. Hopefully, in future, we might do away with adrenal venous sampling, which is a complicated procedure. But still, it's not standardized, and still AVS is considered gold standard. So we saw this very challenging case of a young girl who had a 24-year female who was on 6 antihypertensive agents and drinking potassium in such high doses, yet had hypokalemia. In this case, she had one of the highest aldosterone level I've ever seen in my life. Her aldosterone was 2070. Just imagine, we are talking about 10 as more than 10 as positive. She has 2070 nanogram per deciliter. The ARR was extremely high, and then she had a KCNJ5 mutation. which confirmed the diagnosis of familial hyperaldosteronism type 3. She underwent bilateral adlectomy and she is now doing well. She has normal potassium and she's off antihypertensive agents. Now coming to this very interesting this algorithm given by Dr. Vaidya, who is working from Harvard. First thing to do is to measure aldosterone and renin. Look at renin. Don't look at the ratio. Look at renin. If renin is suppressed, then look at aldosterone. If aldosterone is also suppressed, then primary aldosteronism is unlikely. If aldosterone is more than 15 and have hypokalemia, it is overt aldosteronism. Just go directly to CT scan. But if it is in the middle range, then there are two options. Also going for an empiric MR antagonist therapy if the patient is not willing for further workup. However, it is better to complete the workup, and in this case, we will do a confirmatory test and do a CT scan and then imaging and AVS to confirm. So the first step is to look at renin. Now, once we have the confirmed primary aldosteronism, we can do AVS and do adrenalectomy. If bilateral disease, then we can go for lifelong MR antagonist therapy. One very important thing, while the patient's on MR antagonist therapy, we have to give optimal dosing. So what is the optimal dosing for MR antagonist? So it's that the renin should rise. If you are treating it properly, you should measure renin. And the renin should increase. If it is still suppressed despite being on MR antagonist therapy, it means that you are not treating it properly. So these are some of the aldosterone renin report which we see in the clinic. It's very confusing. They report it in such a way that you are totally dumbfounded by these reports. So instead of seeing these values of ratio, just see the aldosterone and renin individually. And you can say whether it's positive or negative. So in this one, aldosterone is 40.4, which is positive. Direct renin is 9. Less than 12 is called suppressed, so it is positive. In this case, it is very clear it is positive. Aldosterone more than 100, direct renin suppressed. In the third case, also aldosterone 33, direct renin low. It's also positive screen. And in this last case, also aldosterone is 9.28, direct renin 0.5. And this one is positive. But if you look at all the units, it's funny the way they are reporting all kind of units. Like there's no standardization. Somewhere they will report as nanogram per MIU, somewhere nanogram per deciliter per micro IU per ml. So you are if you don't have previous experience in dealing with cases, you will be baffled by these reporting of different labs of aldosterone and renin. So I just lastly would say that primary aldosteronism, adrenal hypertension, we are not even addressing the tip. So the big chunk is below, and we need to do more. I would like to give special thanks to Professor Rajesh Karkawat from AIIMS New Delhi, who was my chief guide during my dissertation. Thank you.